Good evening all. I'm Dr. Gurusanthiya and will be discussing about lung mechanics and anesthesia today. And the overview of the chapter will cover anatomy, physiology of respiratory system, the ventilation, perfusion, the mechanics such as the respiratory compliance and the resistance, the lung volumes and capacities, a brief note on equal pressure point and the control of breathing, and what are the changes of respiratory system under anesthesia, and what are the effects of anesthetic agents on the respiratory system, and a last note on hypoxic pulmonary vasoconstriction. So the anatomy of respiratory system basically starts from the nasal cavity, which was involved in the quiet breathing, and goes through the larynx, trachea, the bronchi, and the bronchioles, and the alveolar ducts, and the alveolar sacs, and the exchanging units. And from the circulation side, it is the pulmonary capillaries, and supplying the lungs is the bronchial arteries. And in the conducting system in the airways, there are 23 generations of airways which is involved in humans. And trachea, it starts at 0. From 0 to 15, it is the gas conducting system. It is not involved in any gaseous exchange until the respiratory bronchiole, which is the 17th generation. And the gas exchanging components start from the respiratory bronchioles, which is 17th to 19th generation. And the alveolar ducts and the sacs constitutes the 20 to 23rd generations, which are primarily involved in the gaseous exchange. The muscles of respiration. Inspiration is an active process, whereas expiration is passive. During inspiration, the main muscle of inspiration is diaphragm. The diaphragm, the dome descends downwards during inspiration and increases the vertical height of the thorax and also causes increased negative intrapleural pressure, and that aids in inspiration. The accessory muscles of inspiration are sternocleidomastoid, anterior scalene, middle scalene, and posterior scalene. Another inspiratory muscle which is normally working is the external intercostal muscles. This helps to elevate the rib, and the accessory muscles also helps to elevate the rib, and sternocleidomastoid elevates the sternum, thereby increasing the anteroposterior as well as the lateral diameter of the chest and helps in inspiration. Normally, expiration is a quiet process. It is from the passive recoil of lungs. Suppose if the patient has got any respiratory illness, then it becomes a passive process, and the muscles aiding are internal intercostal muscles and the abdominal muscles, which includes rectus abdominis, internal oblique, and transverse abdominis muscle. And these are the accessory muscles of expiration. And the normal physiology of respiratory system is to aid in oxygenation and remove the carbon dioxide from the body, and it is achieved by ventilation. What is ventilation is fresh gas reaching the alveoli for gaseous exchange, and the gaseous exchange depends on what is the volume of air you are giving in and what is the volume of air you are removing out. And normally minute ventilation is normal tidal volume into respiratory rate. Tidal volume is the normal amount of air which you will inhale or exhale during a quiet breathing. So the minute ventilation is tidal volume into respiratory rate. So what is dead space? Dead space is any amount of air that you have inhaled but that is not taking part in gaseous exchange is called dead space. The dead space can be of two types. One is anatomical dead space and the next is alveolar dead space. The anatomical dead space is the one which is the volume of air which is present in the conducting airways. And the alveolar dead space is the one, the alveoli is ventilated but the alveoli is not perfused. There was no blood which is flowing through the alveoli to take part in the gaseous exchange, and that is a alveolar dead space. Normally, alveolar dead space is very negligible, and these two dead space constitutes the physiological dead space. And the anatomical dead space is actually 2 ml per kg. It is measured by Fowler's method, wherein one will breathe 100% oxygen for a single breath after normal expiration, inhale maximally, and breathe through a nitrogen analyzer. So that will give us the anatomical dead space. The anatomical dead space, say you are inhaling somewhere around 450 ml of tidal volume and the gas is moving into the alveoli. Once when the gas is moved into the alveoli, only 300 ml of air enters for gaseous exchange and this 150 ml of air remains in the conducting airways. And this 150 ml constitutes the anatomical dead space. So you say if the bronchus is constricted, then the dead space may come down. If the bronchus is dilated, then the dead space may come up. Say if you are extending, if you are increasing the length of the airway by neck movement, say you are extending and you are increasing the length of the anatomical dead space, then the volume also will get increased. So neck movements, head movement, if you are placing an ET tube, you are bypassing all the way from here to the neck. So the dead space will decrease. So any change in bronchial tone, head and neck movements or ET tube, the dead space will increase or decrease depending upon increasing or decreasing the volume. So what is alveolar ventilation is whatever the fresh gas which takes part in the ventilation is called alveolar ventilation. Now we have seen that the dead space, anatomical dead space is not taking part in the gaseous exchange. Hence, the alveolar ventilation is this is VA, it is equal to respiratory rate into the normal tidal volume which you have inhaled minus the dead space. Suppose you said dead space is 150 ml and the tidal volume is 450 ml and the respiratory rate is somewhere around 12. So it becomes 12 into 450 minus 150, which is somewhere around 300. So the alveolar ventilation is the only volume of air that is actually entrained into getting the gaseous exchange. So next coming on to alveolar dead space. As I've said earlier, the alveolar dead space is the volume, the gas, inhaled gas has passed through the alveoli, but the blood has not passed through the alveoli. And this constitutes the shunt when the lung is ventilated, but it is not perfused. So this alveolar dead space in normal lung, it is not that much significant. Only anatomical dead space is significant. But in case of pulmonary embolism or in case of COPD, what happens is this is the anatomical dead space. Up until here is the anatomical dead space. So this whole amount of alveoli through which the air has passed and the alveoli is ventilated, but because of pulmonary artery occlusion, this area is not getting perfused and not taking part in gaseous exchange. And hence, this also constitutes the dead space. This is alveolar dead space. The same happens in COPD, as in there is increased inflammation of the airways or there is edema in the airways. There, the blood flow is coming, but then because of the deficient transition from the alveoli to the capillaries, the dead space occurs. That is also alveolar dead space. So alveolar dead space also does not take place in the alveolar ventilation. Coming on to respiratory mechanics, which includes lung compliance and lung resistance. So what is compliance is the respiratory compliance consists of static compliance and dynamic compliance. The respiratory compliance is whatever may be, compliance is change in volume for change in pressure. Here, the change in pressure is the transmural pressure, which is otherwise called as the transpulmonary pressure. So we'll discuss about it later. So the distending pressure for the lungs is the transpulmonary pressure. So here, change in lung volume per unit change in transpulmonary pressure is the respiratory compliance. It is usually somewhere around 100 ml per centimeters of water. And the static compliance is change in lung volume per unit change in pressure when there is no airflow, when there is a static airflow. That is called as the static compliance. And both static and dynamic compliance has chest wall component as well as lung tissue component. And dynamic compliance is where change in volume per unit change in pressure, which is measured during a normal breathing. So between points of two apparent zero flows, that is, you measure one at beginning and one at the end of inspiration, and that is the dynamic compliance. As you would say, 1 divided by total respiratory resistance is equal to 1 divided by chest wall compliance plus 1 divided by the lung tissue compliance. And so the factors affecting compliance are most of the parameters of our respiratory system will be maximally beneficial to us at the FRC level. So compliance, it is maximal at FRC and also in standing position. The compliance will also come down in supine position in elderly and in infants. When there is high FRC or low FRC, the compliance is decreased. In pregnancy and in ARDS and pulmonary edema also, the compliance is decreased. And the chest wall compliance is primarily decreased as in case of obesity, chest wall edema, any disease of costovertebral joints, and also in case of pleural effusion. So coming on to pressure volume loop, this is a function of compliance and hence I am discussing it here. In this pressure volume loop, which has involved the total lung capacity and the residual volume, we are taking only the normal quiet respiration, which ranges from FRC to FRC, and this has been extrapolated in this graph. As you can see, the intrapleural pressure is always negative for a normal quiet respiration. So say somewhere around -5 centimeters of water, the inspiratory curve and the expiratory curve do not share same points. If they were about to share same points, then all the points will be on the same line and there will not be any loop. The difference between the inspiratory curve and the expiratory curve is because the inspiratory compliance is different from that of the expiratory compliance. As you can see in this graph, say the negative intrapleural pressure of -6 centimeters of water. See the lung volume, it is somewhere around just above FRC. As you can see, it is just above FRC. Mukta, can you allow the people, please, because my screen is getting tampered here. Okay, so -6 centimeters of water. See, the lung volume is just above FRC. But for the same negative intrapleural pressure, the lung volume at expiration is greater than what it was for the inspiration. This difference in the inspiratory curve and the expiratory curve happens because of difference in the compliance. And this difference in curve and the formation of loop, as these points do not share a common point, is called hysteresis. This happens because of the effect of surfactant, the relaxation techniques of the lung tissue, and because of alveolar recruitment and de-recruitment, which would happen simultaneously during inspiration and expiration. So the inspiration, the negative intrapleural pressure increases as the diaphragm descends, the intrapleural pressure reaches maximum, and the compliance curve of expiration is actually quite different from that of the inspiratory curve and reaches the same point of negative intrapleural pressure. So this loop is called hysteresis, and in case of pathology, this is a compliance curve because you are measuring change in pressure with change in volume. So this is a normally compliant lung. So for change in -0.5 to 1 Pascal, there is rise in volume of 3 liters to 2.5 liters to 3 liters. As you can see, increasing volumes increases the compliance, increases the increase in pressure increases the volume. But in case of fibrosis, you see have increased from 1 Pascal to 1.5, 2, 3, 5 and 3.5. But the lung volume has not increased much because fibrosis is a restrictive disorder and all the lung volumes and capacities tend to decrease in case of fibrosis, and hence it is a very less compliant lung. Coming on to asthmatic emphysematous chest. See, for 0.5 Pascal itself, the curve got over, which means it's a very highly compliant curve in case of emphysema. But this does not add any clinical benefit because the airway resistance is also increased and concomitantly the lung volume is also hugely increased and the expiration becomes a very active process in case of such a compliant lung. The same happens with asthma and bronchitis. It may look like a highly compliant lung because you're increasing the increase in volume for a unit change in pressure is high, but this will not translate into a clinical benefit because this is also associated with increased resistance. Since this curve shows only compliance, the resistive properties is not mentioned, and this increase in compliance does not yield any clinical benefit in patients with asthma and emphysema. And coming on to the pressure volume relationship of